Thank you very much for having me. Thank you. So if you don't recognize me from the picture, it's because I'm about 30 years old. So I'm happy to come over to the other coast of Florida, get away from the hustle and bustle of Miami to more serene parts of the state. And it's always nice to catch up with fellow former residents at dinner last night. And I'm also happy to be here to talk to you a little bit about intracerebral hemorrhage. We've heard quite a bit about all kinds of technological advances in subarachnoid hemorrhage. And I have to admit that in intracerebral hemorrhage, treatment options are still a bit lacking. I think it still remains the only stroke subtype for which we really have no disease-specific treatment. So what I wanted to do is discuss a little bit about the epidemiology, some of the risk factors, and then get into an important differentiation between lobar, which is cortical on the surfaces of the brain, and deep intracerebral hemorrhage, because the two have different causes and the two behave a little bit differently. And then discuss in that context a bit about the risk of recurrence, and then focus for the most part of the talk about the acute management of intracerebral hemorrhage. So looking at worldwide stroke epidemiology, we've seen that there has been a 40% reduction in general stroke in high-income countries and a 100% increase in low and middle-income countries. And this has really been driven by ischemic stroke. If we look at intracerebral hemorrhage, or hemorrhagic stroke, there really has been not much of a change in the last 30, 40 years. And there is a lot of regional variation and race ethnic variation in terms of intracerebral hemorrhage, with the highest rates seen in Eastern Asian countries. The median fatality has not changed much either. A lot of our patients still die, and functional recovery still continues to be very poor, with only about 20% of our patients gaining functional independence at 6 months or so. Here you see some of the regional variations, the high rates in the Eastern Asian countries. Usually we think of our Black and Hispanic populations, which are particularly pertinent down here in South Florida, to have higher incidence of intracerebral hemorrhage than sort of the reference group, which is generally the whiter population. There has, however, been a bit of a shift in the demographics of intracerebral hemorrhage. So the overall numbers haven't really changed much, but this study out of England shows us that over a 30-year, sort of a 20-year period, they've noticed that the numbers have stayed about the same, but fewer hemorrhages are occurring in the young, so less than 75, and more hemorrhage tend to be occurring in the older population. And the authors of this study sort of attributed that to more improved blood pressure control, which remains the single most important risk factor for stroke in young patients, so more prevention because of blood pressure control, and then alternatively a higher incidence in the elderly population because we're using more and more antithrombotics, dual antithrombotics such as aspirin and clopidogrel together, which then results in a higher bleeding rate. Bringing this a bit more closer to home, these are the numbers for the US, about 70,000 hemorrhages a year, disproportionately affects our minorities, typically younger than ischemic stroke patients, so more morbidity, more loss of productivity, and to date is the least treatable stroke subtype. Now, intracerebral hemorrhage generally falls into the spectrum of what we call small vessel disease, which most of it is mediated by hypertension, and then to some extent by something that's called amyloid angiopathy, which I will tell you about in a second. And here we see the different manifestations of small vessel disease. We see patients with white matter changes on MRI, so thickening, chronic microillustratory damage. We see little microbleeds, which we can see on the surface, or we can see them deep. And then we see here lacuna stroke, which are occlusions of small penetrating arteries. And here we see a larger, older hemorrhage that gave rise to an intracerebral hemorrhage. And this is the one we'll be focusing about. And then sometimes we see cortical hemorrhages related to amyloid angiopathy as well. So hypertension is far the most important risk factor for intracerebral hemorrhage. Typically, these hemorrhages occur in the penetrating arteries of the brain. So these are causing deep hemorrhages in the thalamus, in the basal ganglia, in the brainstem, and then the cerebellum. And it's just as a result of sort of the chronic wear and tear of high blood pressure, the small penetrating artery leading to thickening and ultimately rupture. Sometimes there might be microaneurysms associated with that. And then we have this other condition that affects our elderly population more. It's called cerebral amyloid angiopathy, where the arteries on the outside of the brain, the cortical arteries, get this amyloid protein deposition, leads to weakening of the arteries, and then for some reason, breaking of the artery and a clinical bleeding type of stroke. This is how we diagnose this. We need pathology for that, and we have special staining and then the special microscope, which then shows us this type of bleed. I'm going to skip that, sort of differentiating these deep hemorrhages from these amyloid hemorrhages. So it's usually the hypertensive hemorrhages occurring in our younger population. They tend to be smaller, they tend to be deep in the brain, tend to be rounder. And generally, if we control high blood pressure over the ensuing months and years, the risk of recurrence is pretty low. Now contrast this with a typical amyloid-related hemorrhage. They tend to be, patient population tends to be a little bit older, largely white, if you can generalize. Hemorrhages are larger, more lobulated. They sometimes, because they're on the outside of the brain, have a subdural component and a subarachnoid component, which helps us differentiate them from hypertensive hemorrhages, and often occlude the posterior lobes, the temporal lobes, and the occipital lobes, and in general have a very high recurrence rate after the initial hemorrhage. So here are some examples of amyloid-related hemorrhages. You see them on the outside of the brain. You see a subdural component over here. You see a bit of perhaps subarachnoid component over here, multilobulated and larger. There are some research criteria that have been established. These are the Boston criteria to make diagnosis of amyloid angiopathy, because ultimately you do need some pathological specimens, but we can get a pretty good feel for whether a patient has amyloid angiopathy by looking at something on MRI scan that's called gradient echo imaging that's very sensitive to small blood products. And you can see these little black dots on gradient echo imaging that suggest petechial hemorrhages, small microbleeds, suggesting that this patient may have amyloid angiopathy. Here you see a larger hemorrhage over here. This was the clinical hemorrhage. We imaged him with gradient echo, so all these little dots, which were subclinical, asymptomatic, and we're pretty confident in terms of making this diagnosis. Now let me switch a little bit to the acute treatment and pathophysiology of intracerebral hemorrhage. And what I wanted to do is show you two cases that demonstrate to us that there might be a window of opportunity where we actually can intervene to improve patient outcome. So look at this case over here. This was a fairly young gentleman with very high blood pressure uncontrolled, comes to us with left hemiparesis, left-sided sensory loss, and then while in the emergency room, 4 hours after the stroke onset, deteriorates, becomes comatose, and does not wake up anymore. And I'm showing you here the initial CAT scan that we obtained at about an hour and a half after his stroke, when he presented to us first in the emergency room, and then the follow-up at 4.5 hours. And you can see that you go from something that's pretty manageable to something that really has become unmanageable right underneath our hands. Now contrast this with a different case. This is an elderly woman, again comes to us with left-sided weakness, is responsive initially, follows commands, has left-sided weakness, and then 72 hours after presenting to us becomes increasingly obtunded and begins to lose her mental status. And here we see the initial hemorrhage, here we see the follow-up hemorrhage at 72 hours. The hemorrhage is about the same, but we see a lot of midline, a bit more midline shift, a lot of edema surrounding the hemorrhage. Again, somebody who deteriorated underneath our hands while in our care, suggesting that there may have been something that we can do to prevent this from happening. So what exactly happens acutely when somebody has an intracerebral hemorrhage? So you have the first event of actual vascular rupture. You know, why somebody bleeds all of a sudden is not clear, perhaps related to blood pressure spikes as a result of these chronic microvascular changes. And then over the next hour or so, you get the actual event of hematoma formation. So the bleeding continues, the hematoma forms, causes more mass effect. That might depend on blood pressure, that might depend on sort of local coagulation abnormalities, perhaps even some mechanical distortion from the tissue that then leads to more bleeding. And this is demonstrated here on this diagram. This was an original study from C. Miller Fisher, who was a neuropathologist and a neurologist who did a lot of pathological work in stroke. And what he did, he looked at this hemorrhage in the pons, and he looked at the arteries surrounding the hemorrhage, and he noted that a lot of them were disrupted, even though intrinsically they had very little damage from high blood pressure, suggesting that as the hematoma forms and grows, that it starts tearing up these arteries that are nearby, and the whole thing sort of cascades on itself until it reaches some sort of equilibrium where it then stops. And we can approximate this perhaps clinically by doing a CT angiogram and looking for what's known as a spot sign. So this is actually a leaking artery where the contrast from the CT scan is leaking out, suggesting that this patient has continued ongoing bleeding. And in fact, if we see this spot sign on the CT angiogram, then these patients are at high risk of having a hematoma expansion, continued bleeding, and then worse outcome as a result of that. Now, 30% of intracerebral hemorrhages will have hematoma expansion, defined as an increase of 30%. Most of that really occurs within the first few hours. There are unfortunately not many good predictors, no clinical predictors. Perhaps the spot sign that I've just shown you might be one way of sort of targeting and picking out these patients. And this reminds me of a day when I was on call at Jackson Memorial Hospital. I had two patients who literally came in within hours of each other. They were both about the same age. Both had a history of high blood pressure. Both came to us within the first few hours after their symptom onset. Both were taken care of by the exact same medical team. And you can see that the initial scan is very comparable, and then the follow-up scan, very much different. This patient sort of had a massive expansion of the hematoma. This one stayed the same. Why this happened is not clear, because they really received essentially the same treatment. So what happens after that? So the hematoma forms, continues to grow perhaps. At some point, probably in the first 6 hours or so, eventually stabilizes. And then we get into a whole host of secondary events surrounding the hematoma that might lead to more damage. So there's inflammation, there's neuroinflammation, there's breakdown of blood, cellular infiltrate, blood products. We think that blood is toxic to the brain. So there's a whole series of molecular events that we could intervene with to help in some way protect the brain. Now, experimentally, we know that this cell death continues for 3 or 4 days. In the past, we thought that there might be ischemia surrounding the hematoma because you have mass effect, you have perhaps decreased perfusion to that area because of the mass effect, leading to ischemia and then more cell death. Now we are understanding that there probably is some sort of metabolic penumbra around the hematoma, meaning that there are all kinds of metabolic events that then contribute to cell death that may be salvageable. Now, what about trying to limit this hematoma expansion? So how can we prevent this hematoma from growing? So the reason why people bleed is probably because of hypertension in the first place. So intuitively, it's very appealing that if we treat the blood pressure aggressively, we could perhaps decrease the rate of hematoma growth. In the past, there's always been a theoretical concern that if we drop the blood pressure too much, we actually might cause ischemia surrounding the hematoma just from mass effect. I think Dr. Miranda has shown you this formula that cerebral perfusion pressure, so the pressure going up into the brain, is the difference between the mean arterial pressure, so the blood pressure, minus the intracranial pressure. So if the intracranial pressure goes up, if we lower the mean arterial pressure, we decrease the cerebral perfusion pressure and perhaps cause ischemia. That's been more of a theoretical concern. We've done PET studies, we've done diffusion-weighted MR studies, see what happens around a hematoma when lowering the blood pressure, and this whole ischemia concept has never really been demonstrated. So now there is sort of a feeling that the tissue surrounding the hematoma undergoes a lot of molecular changes that put it sort of in distress. For example, glucose consumption is up, oxygen consumption is down, so a lot of anaerobic metabolism that might then lead to cell death. What happened here? So sort of summing up, where can we intervene? So one, if we do it hyperacutely, we can sort of prevent hematoma formation and expansion. We can then subacutely look at cells, a way of preventing cell death surrounding the hematoma. And then we can do a whole host of other things, metabolic things, treating fever, treating glucose, and prevention of DVT and other secondary complications to improve outcome. Now, in terms of hematoma formation, We have looked at the issue of blood pressure control and hemostatic control. Hemostatic control means giving medicines that help plug up these leaking blood vessels. Blood pressure control is intuitively very appealing because what I've mentioned earlier. I have listed here the guidelines for the blood pressure treatment over the last 10 years, and you can see that they have progressively gone down. Back in the 1990s, the recommendations were to lower the blood pressure in acute intracerebral hemorrhage to a mean pressure of 130. This then went down to 110, and the most recent updated guideline, it's sort of recommended that it may be safe to lower blood pressure to a systolic pressure of 140. And this is what we do for the most part in our patients when they present to us acutely. We try and lower them to 140. The rationale for this is from the Interact trial, which was a very large trial, acute intracerebral hemorrhage within 6 hours, randomized to either a systolic pressure of 140 or a systolic pressure of 180. Unfortunately, it just barely missed statistical significance. So there seems to be some effect, perhaps not as dramatic as we would have hoped for. If we look at some of the secondary outcome, for example, here, the neurological disability, there was a benefit, again suggesting that there's perhaps a modest effect in being aggressive with blood pressure reduction. Very interestingly, the rate of hematoma expansion really wasn't different between the two groups, which was actually the target of the therapeutic target here. Now, what do we use to control blood pressure? We like nimodipine infusions. I think they're easy to use, usually pretty effective. If the blood pressures are not that elevated, we use intermittent labetalol or enalapril, and very rarely we'll have to resort to nitroprusside. Now, let me introduce a relatively new concept now that may be tied in with this whole issue of blood pressure control issue. We've now come to realize that if we do diffusion-weighted imaging a week or 2 weeks out after an intracerebral hemorrhage, we start seeing these little ischemic lesions. So in diffusion, remember, bright is acute ischemia, and a good number of patients after intracerebral hemorrhage will have these little ischemic lesions. And it's not clear why these are happening. Some people think this is just a manifestation of an underlying small vessel vasculopathy that is acting up. It might be the adrenergic stress from the hemorrhage leading to small spasms or platelet microemboli causing these. And there's some concern even now again that this might be related to these blood pressure fluctuations that patients undergo in the first few days or so. Here's another example of somebody who came to us with a left thalamic hemorrhage, had a good number of these lesions, a quite impressive blood pressure change, and there seems to be some correlation. So the final word on how aggressive to lower blood pressure may not be out. At this stage, at least, we think that lowering it to 140 or so is probably safe. Now, what else can we do to prevent this hematoma growth? There was a whole series of experiments and studies looking at factor 7. Very disappointing, because at the end of the day, factor 7 cannot be recommended for the treatment of acute intracerebral hemorrhage because it did not work. Now, there are some certain special circumstances where you might want to consider hemostatic therapy. And that's in the setting of somebody who might be using antiplatelets, and certainly if they're using anticoagulants. In the past, it's been warfarin, and now some of the newer agents more recently. So this is looking at the outcome of somebody who has an intracerebral hemorrhage who's taking, for the most part, aspirin over here. Not much an effect on disability, but an increased effect on mortality. So if you have aspirin on board, have an intracerebral hemorrhage, you are perhaps more likely to die based on this meta-analysis. And the idea is that you have continued bleeding or so. One way we can intervene there is to give platelet transfusions, and this is something you may want to consider. It's sort of a class 2B, which means you may consider it as a recommendation in the updates the last time in the guidelines. Typically, we don't use it routinely. If somebody's taking dual antiplatelet therapy with Plavix and with aspirin, perhaps we are more likely to do this approach. Now, if somebody has severe coagulation deficiency, thrombocytopenia, then of course you want to replace this as quickly as you can. And particularly if somebody is on warfarin, has an intracerebral hemorrhage, then we have to be very aggressive in trying to reverse the effects of warfarin, because they're more likely to bleed acutely, and the bleeding is likely to result in a much larger hemorrhage, which adversely affects the outcome then. And here you see somebody who has a intracerebral hemorrhage on warfarin. This is a very characteristic image. You see an air fluid level over here. As blood doesn't really coagulate, it sort of layers out as the patient is lying backwards while getting their CAT scan. In the past, we've used a vitamin K and fresh frozen plasma regimen. Unfortunately, it's a bit cumbersome to use. Patients have to be typed and crossed. The plasma has to be thawed. By the time it's administered to the patient, often considerable time will elapse, and it might be too late. So we are moving towards a prothrombin complex concentrate approach in reversing the effects, and this is a concentration of factors 2, 7, 9, 10. You have to be careful. Sometimes one of these factors in the commercial products is missing, so you have to make sure that your institution uses the 4-factor one. And it's easier to use, much faster. Problem is it's quite expensive, and that's been one of the impediments of its use in the past. Officially, the guidelines state that there's no clear benefit because it really hasn't been studied as well as we would like for it to be, but it's certainly a consideration and a very effective alternative in my opinion. Now, what about somebody who has a hemorrhage on the newer agents? Unfortunately, we have no way of reversing them. The makers of the Bigatran, I believe, are now coming up with a targeted antibody to reverse the effects, but that has not been FDA approved. In our practice, we usually use PCC and FFP in combination. Now, what about other things in terms of management? One issue is controlling mass effect. You have these general ways of reducing mass effect with hypertonic saline and with mannitol that we use for general increased intracranial pressure management in other conditions as well. So I'm not going to focus much on these. Another way of treating mass effect is this age-old story of surgical treatment. Unfortunately, for most patients with intracerebral hemorrhage, there's really no clear surgical indication, and the role of surgery is a bit uncertain. So the way we approach this, we think that good candidates for surgery are ones with a cerebellar hemorrhage that's approximately 3 centimeters in size or more than 40 millimeters in volume, particularly if there's compression of the fourth ventricle, because there's very little room in the posterior fossa. You get hydrocephalus early, and these patients can deteriorate very quickly. And then perhaps if you have a young patient with a very superficial hemorrhage that's worsening, and that might be another good candidate. There's no role for surgery in brainstem or deep thalamic hemorrhages. There's no role for ultra-early surgery. You don't have to go in right away and take the hemorrhage out. In fact, that might be dangerous because you can contribute to ongoing bleeding. But for most hemorrhages that are sort of in the putamen, in moderate size, there is really no clear indications that routine surgery improves outcome. So this is somebody, for example, who had a fairly deeper putamen hemorrhage. We went in and took it out. You can see that the surgical tract actually causes damage. So this would be a hemorrhage that we now routinely do not operate anymore. And this was sort of the question then was, are these more superficial hemorrhages like this one that you can get to much easier? You know, do we need to operate on them? And that was sort of the topic in stage 2. But, you know, unfortunately, even randomizing those patients to surgery versus no surgery at the outset of their hemorrhage did really not change management very much. So again, no routine indication for surgery. So this is somebody that we sat on, had a sort of just borderline size cerebellar hemorrhage with some compression of the fourth, and ended up doing well. And this is somebody who has sort of complete obliteration of the fourth ventricle and underwent surgery. And you can see the mass effect on the brainstem that persists. In general, what you do not want to do if somebody presents like that is put a ventricular drain in without doing surgery, because there's a risk of herniating upwards and then brain death. So if you see this, don't have the surgeons put a drain in only, make sure that they undergo a decompression as well. Now, what's ahead? We are looking at minimal invasive ways of trying to get the hemorrhage out. So just putting a little puncture in, maybe stilling a little bit of TPA, sucking the clot out so we don't have these large surgical tracts. And we are treating intraventricular blood with TPA as well, instilling it through the ventriculostomy tube, making sure that the blood then dissolves so you don't have to leave these ventricular catheters in there for that long. Here's the protocol that we like to use. So you do 1 milligram every 8 hours and you don't exceed 12 milligrams, and you do that after the hemorrhage has sort of stabilized in the first day or two. Yeah, so we discussed. And then as a general rule, we sort of manage the seizures. We do not use preventative antiepileptics if somebody comes in with a hemorrhage. Only treat it if you think they're either clinical seizures or subclinical seizures. If you use it prophylactically, there's some indication that outcome is actually worse. We treat glucose aggressively. We treat fever aggressively. We hold any chemical deep vein thrombosis prevention, such as heparin or low molecular weight heparins in the first 48 hours. We use serial compressive device in the first 48 hours, and thereafter then, once the hematoma is stabilized, we move ahead with our heparin or low molecular weight heparin. So I hope to have shown you that we have sort of windows of opportunity, and hopefully with these targeted approach at the pathophysiology of intracerebral hemorrhage, we are going to be able to come up with a treatment finally for this unsuccessfully treated stroke subtype so far. Thank you. Right on time.